everyone. Don't.
So,
Hello. This is.
Hi.
What's happening? Okay. Don't worry. This is not an extension class of PTA 105. I hope everyone got my email from this morning that I have your site selection list ready for your first practicum. And just so you know, normally students are, normally this list is ready 3 weeks before your first day. This time it's ready 13 weeks before your first day. Just got lucky, really lucky. All of my clinical instructors in clinics got back to me really quickly. And so you have extra time, you know, you'll know where you're going a lot earlier. And I didn't want to wait to post this, even though I'm only supposed to really post it 3 weeks ahead of time. But I know that with your other life activities like childcare, job schedule, elder care, anything like that, that it helps if you are able to know where you're going to go as far ahead of time as possible. And you may even be able to find out your schedule sooner than normal too. So you can make sure that everything in your personal life is arranged in a way that makes your clinical schedule doable. So what I want to do today is just to take like 5 minutes and explain the site selection list, and then what we're going to do next Monday when you get to actually choose your site from that list. So anyone who has an early placement done, you're not going to participate in this process because you're already placed. So this is just for the, it's about 20 people that are going to be picking their sites from this list on Monday. So you have the whole weekend to look over this list and to look at these places' websites. First, I'm going to, I have to get back to, sorry, there's one thing I want to, oh no, I can show you from somewhere else. Cohort 12. Okay, now I'm ready to share a screen. Okay, so here, just a reminder, here are the site selection list ranking orders for like when do you get to pick your practicum. And so obviously we are doing practicum 1 for August. And this is, so this list below here is the order. And I included that in the announcement that went out today, just to remind you what your ranking number is. So obviously TJ gets to go first, and then John, and then so on and so forth down the list. Okay. And the last one who's not placed for, I don't think Diana, is Diana? Diana, are you placed for early placement? I can't remember right.
Yeah, I'm in California.
You are. So
Yeah.
Mara's going to be the last one to pick. And then of course, you know, these guys are really low on the list here, and they get to be really high on the list for the next practicum. So again, we try to make it as fair as is possible. So now I want to look at the actual list that I sent you the link for. And
so we're picking, sorry, Dr. Breskin. So we're picking on Monday. So we'll just log in to see like who, it'll just be our responsibility to see like who's chosen, like the person above us already chose, so we choose. Is that how it's going to work?
yeah, so so let's say on Monday, I'm going to contact TJ around lunchtime, because that's, you guys are an afternoon cohort. So your day with Pima starts around 1, right? So I'm gonna, well, I don't know. Actually, TJ, you can tell me as early as you want on Monday where you want to go. You can just send me the name by email. And then what's going to happen is I'm going to come to this list, and you see how everything is, all the names are blue here. When someone picks a site, I'm going to do this and this. I'm going to cross it off and turn it orange. That means it's taken. And so you can monitor this list in real time. And you'll know that only the blue ones are available.
But then you'll contact us when it's our turn.
Yes.
Okay.
Yes, I'll email you. And if someone, let's say TJ tells me his choice at like 9 a.m. and then I'm like, okay, I can't remember who's next on the list, but I'll contact the next on the list. And let's say they're driving their kids somewhere or something like that, and they don't get back to me for 20 minutes, then I wait 20 minutes. I'm not going to skip over them. I'm just going to wait until they get back to me. And if anybody wants to, if anyone has a question about a facility or they would like my guidance on what they should pick, I can meet with you by Zoom instead of just having you email me. So you have your choice. You can either email me your choice of what's left, or you can say, I want to meet by Zoom, and then we can get on my Zoom room. Okay. So I want to go over these directions, and then I like up here, I can see that people are viewing the list. That's cool. Okay, so there are some guidelines to help you to know what kind of behavior is okay in this situation and things that you should not do. So you're going to read over the list and decide on your preferences. The example that I sent you in the announcements is, let's say you're number 5. So you need to make a list of your top 5 picks, because 4 people ahead of you are going to be picking sites and you don't know which one they're going to pick. So you need to have 5 ready to go that you want to pick. And I would put your list in your own preference order so that you aren't confused at the last minute about which one was your top pick. Okay. So, and if you're number 20 on the list, then make a list of the top 20 of your choices so that you have them already picked out and by Monday. You can research these clinical sites by looking at their websites and maybe even their social media accounts. Do not interact with them by social media. Do not contact them in any way. So if you're on their social media accounts, don't post a question like, hey, what's your schedule for students? Okay, that you're not allowed to inquire or to contact them in any way until we have chosen the sites and I give you the contact information. Okay, you're allowed to read their websites and read their social media, but do not reach out to them. Don't call them. Do not knock on their door. Don't go into the clinic. That is so much of a bother to them that they will stop taking PIMA students altogether if students start doing that. They can't handle extra communication like that, okay? And it's considered, and if a student calls them or posts a question on their social media, they're gonna contact me and say, why didn't you tell them not to ask us questions? They're gonna blame me and they're gonna blame this school, and they're gonna say, well, we're not gonna take any students, so cancel us if the students are gonna try to contact us, okay? That's just the way it is. I'm sorry. So the description you can go off of is the website, reading their social media posts, and I also have clinical site description forms filled out for each facility that lists what kind of things they have there. Do they see post-op patients? Do they see pediatrics? Do they see geriatrics? So you can get that kind of information from these forms, and I can share those forms with you if you send me an email asking. So if you're like, I'm interested in these 2 places, but I just want a few more details, can you send me the clinical site description form that you have on file? And I can do that. Okay, is everyone very clear that you cannot contact the facility or the staff in any way, even if you know people that work there? Are you all clear on that?
Yes.
Thank you. Good. Okay, so I wrote in several different ways, do not contact the facility or the staff. Okay, again, here's the key. Blue means that clinic is available. Orange means it is taken. And you will start to see orange on Monday when people start to pick their clinics. Here is a key for some abbreviations. SCCE stands for Site Coordinator of Clinical Education. And what that is whoever is at that clinical site that coordinates students. Most sites have someone who's like that, and that's my contact. They make decisions about who the student is going to be with every day, you know, who their clinical instructor is going to be, and they often will help decide the schedule as well. For some locations, they also decide what location you're going to be at. Let's say a company has 5 clinics, and they tell me, we'll take a student, we're just not sure what location they will be at. We'll tell you after you send us the student name. And so sometimes I can only tell the student it's going to be in Las Vegas somewhere, or it's going to be in Pahrump, or it's going to be in a general location. But the SCCE oftentimes will say, I'll tell you where the location is, you know, a couple of weeks before we start. So you might see that on written on some of the clinics that they don't know the exact location yet. And that's out of my power, sorry. I mean, I can't say, tell me the location or I'm not sending a student, because they'll just say, well, cancel us, we're not taking a student. And then I end up with not enough spots, and then someone can't continue in the program. So I have to take the spot with the conditions that they put on it. And I just want you guys to understand that. Oh, outpatient is spelled wrong? So it is, thank you. I always type that wrong. Okay, so here's some more abbreviations. OP, outpatient, IP, inpatient. Rehab means a rehabilitation type setting, which is usually inpatient. The patients sleep there, and they're there for a long period of time, like weeks to a couple months, working on their recovery. Ortho means orthopedic, neuro means neurologic, and LTAC means long-term acute care, which means people who have just come out of the hospital, either from after an operation or after an injury or after a stroke or something like that, and they still need a lot of care. They're not ready for a rehab setting quite yet. I think I didn't put SNF in here, NSF, but I don't, SNF. I'm not sure I have any SNF settings, but I'll put that in there anyway. Oh, now see, I'm screwing up my whole thing. Shoot. Just in case it's in there and I forgot about that. COVID-19. I've listed what I know. I reached out to all these facilities and asked them, do you require a COVID-19 vaccine, so that I can let students know? And the ones that responded to me, I put their response in the blue box with the blue wording. Not all of them responded. And so, sorry, you're going to find out when you contact them if COVID-19 vaccination is required. If it is required, if you have picked that facility and then you find out later that COVID-19 vaccination is required and you don't have it, you have 2 choices: get the COVID-19 vaccination, or you're going to have to wait because there are no other spots. You're going to have to come back with the next cohort and restart your program then. And then you also take the chance then that most of the facilities will want COVID-19 vaccination. And then you'll have to decide, do I get the COVID-19 vaccination or do I not continue in the program? So again, sorry, that's just reality. That's how it is. And even if on this list, the facility says COVID-19 vaccination is not required, but it's preferred or recommended or desired, they could change their policy at any time. And you are obligated to abide by their policy, or you make the decision to leave the program. That is just reality. Okay. And you cannot come back to me and you cannot go to them and say, well, it said on the list that I chose from that you didn't require it, so that's why I picked you. That's not a valid argument. You have to be grown up and professional and you make your decision. Am I going to get the vaccine because they now have decided to require it, or am I going to withdraw from the program or delay my progress in the program? And so I'm saying right here, I can't guarantee that if they don't require it now, that they're not going to require it at any time while you're there. Even on the last week, if they start requiring it, then you have a decision. Am I going to go and get the vaccine and finish my last week, or am I going to decide I'm not going to finish and I can't progress in the program? Okay, this next box. Some of the facilities, they feel like 2 weeks is too short. And because they have to do a whole lot of onboarding processes, you know, for orientation of a student, almost by the time they're done orienting you, the first week is done, and then they only have 5 more days with you. And they feel like that's a lot of investment in someone, and they're not willing to do it for just 2 weeks. They want to do it for longer. And so actually, this is really generous that they do this. They combine the 2-week practicum for practicum 1 and practicum 2, which is 7 weeks. And they're much happier with that, because then when you return for your second practicum, they don't have to orient you or onboard you at all. You're already in the system, you know your way around, you know most of the staff, and you can just start treating patients, because that's the whole point of it. And so these places, instead of saying, we're not taking any 2-week students, sorry, they have said, well, we'll combine it with practicum 2. And so if you choose those places, or if you're the last person and that's where that's the only place available, you're committing to return to that place for practicum 2. And most students are actually really thrilled with this, because they don't have to go through site selection for practicum 2. They already know where they're going. They know the people there. It's like going back to see old friends. And they return and they start using the upper level skills that they have from school. And it's really smooth. And so a lot of students actually pick places because they're going to be guaranteed to go there for practicum 2. All right. We were also very lucky because I didn't have to go a long distance to find any spots. We got enough spots here in town for people that wanted to stay in town. And so the first column is the name of the clinic. The second column is the location of the clinic, because some companies have more than one location. There's also the zip code if you need to look up the location. And this 1, 2, 3, 4, fifth column is what type of setting it is and if they have any requirements for the students. So you'll see like here it says, this place offers outpatient and home health, which you really can't get in Las Vegas. There's no place in Las Vegas that will give you home health experience. And so if you think you want to do home health as a clinician, this is this place, and there's a place in Mesquite that will offer home health for students as well. But if this is a strong interest of yours, then you might want to make the 45-minute drive to Pahrump and get some experience doing this. And then, of course, they responded back about COVID-19, so that was their response, that it was encouraged. Okay, and then scrolling down a little bit, well, just going down to the second one, you see in this box for optimal physical therapy in the Las Vegas Valley, the location to be determined by the site coordinator. And that's because they don't know exactly where they're going to be able to have a student, but for this particular spot, it's going to be in the Las Vegas Valley, not in Pahrump. But notice that over here, they don't offer home health because it's in Las Vegas, and it just doesn't, the supervision isn't there for home health student visits. Okay, so this site is guaranteed to be in the Las Vegas Valley. We just don't know where it is because they haven't assessed which staff member can take a student quite yet for August. What else on here? Dignity Health, which used to be called Select, and they also bought out Physiotherapy Associates a few years ago, but they just changed their name to Dignity Health. They have an interesting policy. It's a little different. in that students that do not have the COVID vaccine will have to wear mask, gloves, and eye protection while they are in the clinic. If you have the vaccine, you don't have to wear any of that unless they still have the mask mandate. If everyone's wearing a mask, then you wear a mask. But if they get rid of the mask wearing this summer, but you have not gotten your COVID-19 vaccine and you go there as a student, you're going to have to wear a mask, eye protection, which is like safety goggles or a face shield over the mask, and gloves the entire day. So that's their policy right now. So you can see that different places have very different policies. Okay, so here's one, Encompass Health, Desert Canyon, and you can see in this last box here, Practicum 1 student will return for Practicum 2. So that's one of the places where if you pick that place, you're guaranteed to have a spot there for Practicum 2. Let's see, I don't think there's anything else. And then down here is where I would have listed long distance sites if I had had to use long distance sites, but I didn't have to because there were enough facilities accepted students in the Southern Nevada area that I didn't have to go up to Reno or out of state. Any questions?
I have a question on column 25 of the 35-hour week student will need to do.
Yeah, oh yeah, that's a good exception I wanted to explain. Column 25, ooh, that's Levitt. Yeah, so their schedule there, I happen to know, is 36 hours a week, right? And you need to get 80 hours in 2 weeks. And so I know right away that whoever goes here is going to have to do some hours during their in-between week, the week off between this semester and next semester. And so I wanted the student to be aware of that ahead of time. Now, just because I know about this for this particular location doesn't mean it's not going to happen to other places. Let's say, I don't know, let's say they don't have enough patients for a couple of days in another place, and you don't get 40 hours that week. You may have to spend your in-between week at that place to get enough hours to pass. And this is why I recommend highly to all students, don't make any cruise or travel plans for your in-between week. Plan for the worst and hope for the best. Make sure that you're going to stay in town in the in-between week, or that if you have travel plans that they're flexible in case you have to stay here and do your hours, or if you're at an out-of-town place, an early placement, if you happen to need to do a few extra hours, that you're able to stay there and do that. Because we just, you never know what's going to happen. So just make sure that you have that flexibility. That's going to be the week of, I don't know, September 2nd, I think. Other questions? That was a really good question.
Dr. Ruskin?
Yeah.
Do you think that they'd tell us, like in the beginning of our clinical, or?
Of what? About what?
For the break thing, if we're going to have to do things on the break?
Well, if they tell on your very first day, well, actually, you're going to be emailing them like a hello, an introduction email. As soon as we're done, everyone's done picking this, I'll send you the contact email to do that. And you're going to ask about your schedule. So that's the advantage of letting you guys pick 13 weeks ahead of time. You can know your schedule. And if you look at your schedule and you realize, oh my gosh, there's only 35 hours per week with my clinical instructor, I'm going to have to plan to do extra hours the week of September 2nd. That's how one way that you'll know. The other way that things like that happen are accidents. It's just like, let's say your clinic has a flood and they can't see patients for 2 days while they clean up.
Mm-hmm.
then you're 2 days behind in your hours, and you probably will have to do those 2 days during that in-between week.
Okay.
Okay.
Okay,
So
so
the-
if
sorry,
they
go ahead.
could already give us the heads up of our dates and everything, just like, that's fine. Just be prepared if anything happens.
Exactly.
Okay.
Exactly. Yeah. Because PIMA is not allowed to make exceptions for the 80 hours that you have to get. You have to get the 80 hours.
Okay.
Okay.
You
If we made exceptions, we would lose our accreditation.
Mhm.
You guys we wouldn't be able to give you degrees.
Okay.
We have to stick by if we say you're going to have, our students get 80 hours during the 2 weeks, then we have to make sure that you get those 80 hours.
Okay. Thank you.
Okay.
Um,
That's a great
Dr.
question.
I also have a
Yeah.
question as well. So like I think you might have answered this before, but let's say I'm not sure if any of the offices or the clinics have like 10-hour days.
Sometimes.
So if we have like 4 10-hour days, do we have
Yeah.
to come in for that last day of the week to finish, or?
No, if your clinical instructor assigns you a schedule of 4 10-hour days
Mhm.
per week, that's what you do.
Okay.
Yeah, then you are looking at like a 3 days off a week, right? Which is it's a nice trade-off for those long 10-hour days, or sometimes people have 11-hour days. And so they reach their 80 hours a little more quickly.
Okay. Perfect. Thank you.
Yeah, you're welcome.
And a quick question too, like aside from doing research on their websites and on social media, what would you recommend us do to prepare? Like, is there anything specific that we can do as students to best prepare for our clinical?
Study hard in school. The skills comps that you do in school, those are the exact skills that we ask the clinic to let you do on patients. So like, the modalities skills that you did, skill comps that you did, you want to make sure that you understand all that material really well. And then you're going to be doing skill comps with Mr. McKeever in this class. And so you need to understand everything that you're doing in the skill comp, all the physiology behind it, and then as well how to do those skills and why you're doing those skills. And that's going to prepare you the best for the clinic. Make sense? And also, I'm going to be doing a full orientation for clinical rotations probably about a week before you go. And so you're going to have probably a lot more questions then, but you can always email me questions at any time if you think of something later on. I don't want to take up too much more time in Mr. McKeever's class. So are there any more questions about choosing your clinic for Monday? Usually I give 48 hours, but Friday's not a school day. So I don't want to make you guys like, have to think about school on Friday. So I'm giving you till Monday.
Do we ever get graveyard shifts for any of the hospitals?
No, thank God. Not like nurses do.
Okay.
Never. I have never seen anything past 8 p.m. in Las Vegas. And that's really rare. Normally the latest is 7 p.m., usually at outpatient clinic. Yeah, hospitals tend to go 6 a.m. to 2 p.m. Outpatient clinics anywhere from 6 a.m. to 6 p.m. Good question. All right, so I'm going to turn you back over to Mr. McKeever. Do I have to like unpin myself or something? I will remove the spotlight. Thank you very much.
I will remove your spotlight. Don't worry.
Woo, okay. All right, great seeing you guys. Thank you, Mr. McKeever.
Thank you. I'm going to actually pin Dr. O'Neill now as the spotlight for everyone.
Yay, this is not the ideal way to do announcement after announcement, but I like to join in because I want to reinforce that Dr. Reskin's role is really important to us, and that's her role. So any questions that you guys have, don't send them to me. I'll refer you right back to her every time. She lets me know when there's a situation that, you know, would require or would need my program director hat. Okay, so just so you know, anything, even if it's a question about a clinic specifically, you know, you guys are going to learn no matter where you go. I learned this as a student myself. That I think I've told you guys this story. I wanted ortho. I just wanted sports medicine. I wanted USC to just teach me everything about being an ortho PT. And guess what? Been a PT for 15 years. Hate ortho. Okay, so that's my preference because I did a rotation at an inpatient hospital, fell in love, end of story. My career took a totally different path. Had I been that stubborn student and my director of clinical ed let me be that stubborn student, and our accrediting bodies let me be that stubborn student, my path would have been a little different. Who knows, better or worse, I don't know. But at any rate, that's my 2 cents about clin ed is that that's Dr. Breskin's role. She handles it beautifully for us, and that's what she does. So I just wanted to pop in and kind of touch base again with you guys because she did reinforce the COVID policy. I know you guys might be a little tired of hearing about it, especially those of you that have already gotten your vaccines and are fully vaccinated, and that's wonderful. I wanted to reinforce that, you know, safety and security of my staff and my students are at top priority. And because of that, we have that July 2nd deadline. For those of you that are unable to, choose not to, we will be resuming classes at 100% capacity, of course, with masks, doing what we're supposed to do per Miss Alicia Paris, who is our COVID regulator for our campus's policies, whatever rules she has. Those of you that are unvaccinated will actually participate via Zoom until we are able to demonstrate that we are, that's our expectation. So I just wanted to put that out there that you guys have a good window for those of you that haven't been able to get it yet. Tons of drive-throughs still in town, Texas Station, Las Vegas Convention Center. There, I set my daughter up for hers on 1 day notice. So I just wanted to put it out there that if you are unable to meet this expectation, you know, that is well within your limitations to be on Zoom. So we will have everyone in lab. I'm no longer going to do split labs after July 6th, of course, pending policy staying the same, COVID restrictions staying the same. Matter of fact, they're opening even more, but that doesn't mean that we're at Pima are going to just start walking around, you know, doing all these things that are not necessarily untested. So we'll follow our guidelines that Ms. Parrish sets for us. I don't set those, but that is what the announcement I wanted to make and just really reinforce. You saw all the information that Dr. Vreskin just put out that policies, sites are expecting it. It's because the best experts in our country are saying this is what keeps our population safe, especially the 3 to 5% of the most vulnerable population that you guys actually will be responsible for as clinicians, because those are the ones that can't get the vaccine, the babies, the elders, the people that are immunocompromised. So it's not about you, it's about being a healthcare provider. So that's my 2 cents. If you have questions, I'll be on campus tomorrow. You guys can reach out, you know, and follow up that way. That's the best way to get a hold of me. Okay, so that's my short announcement. Have an awesome day. Thank you, Mr. McKeever. I'm sorry I jumped into your class again. Just know you guys are going to have an awesome semester. This is so much lab hands-on content that you're going to love it. These two instructors that you guys have and your lab instructors, well, myself, you know, I'm all right, but they're awesome. So, all right. So book pickup tomorrow. Good answer. Come in. I think I told you guys, what I say, between 8 and 9. Come in between 8 and 9, check in at the front desk. The book is down the hall. So the book room, Rebecca Michaels will be down there. She'll just check you guys off. Okay. You'll be there with half of cohort 13, the newbies. So be nice to them, give them directions, give them guidance, welcome them, because they'll be there around the same time. Okay. All right. Now I'm leaving. You guys will see.
Thanks for stopping by, Dr. O'Neill. Thanks
Absolutely.
for stopping by, Dr. Breskin.
Bye-bye.
Bye, guys. Enjoy class.
Ooh, that was a lot of stuff.
Mr. McKeever,
Yes.
so it's 280 hours for all of the practicums?
So it's 80 for the first one, and then 7 times 40 is 280 for practicum 2 and 280 for practicum 3. So you have a total of 560. And so 600 total hours.
Okay, so 80 just for the first one.
80 for just 2 weeks for the first one, right? 2 times 40, 80.
Yes.
And
Okay.
then 7 times 40, 280. Wait, 7 times 40, is that right? Yeah, 280, yeah. I
Okay.
just taught math this morning. My brain is fried, okay? Give me a little slack. I see you guys laughing at me, Stephanie. Did everyone enjoy their break? Did you get a little breather? How'd you guys, first day of rehab go okay? Is that fun? Loads of fun? I am obviously nowhere near going to get through my first lesson today, so don't freak out about it. I already knew that. I have adjusted that lesson. So if any of you downloaded my PowerPoint last night, if you look at that PowerPoint now, it now says old. I now have created a new PowerPoint. I'm trying to go to a uniform style for every class I have. So like all of this class's PowerPoints will be green in background. All of the PowerPoints for my Therex class will be, I think I picked gray in background. So that when you look at them, it's easy to differentiate, because I find that if they're the same color, you're like, is this Therex or is this kinesiology? What am I doing? I don't even remember anymore. And it was a lot worse when I taught kinesiology, Therex, and rehab, because then you had me for everything, and that was just terrifying for all the students. So yeah, I think that was a mistype. I've talked to Dr. O'Neill about this. Class does not go till 5:30. So in next semester, my rehab class does go till 5:15. There's a 15-minute, because of the requirements for neuro rehab, there's a 15-minute add-on that I have to do, if that makes sense. So this semester should only be 4 hours. I'm going to talk to Dr. O'Neill about it, so don't freak out yet about that, please. I just noticed that this morning myself. I was looking at my schedule. I'm like, 5:30? How did I miss that? So you should just be 4 hours. I think what it is, the morning group is now 8 to 12. So I think somehow she got thinking that you guys were like 1:30 to 5:30. I don't know. It's what happens when we make changes. Things get messed up. So other than that, did anyone do anything interesting on your break? Or is it all just boring stuff? Anyone go anywhere?
I went camping in Flagstaff for 3 nights and then had a night in Sedona, so that was fun.
That's very relaxing. I was prepping for this course for the entire week, so that was my job. Huntington Beach, oh, I slept and slept some more. Yeah, that's useful. I was like, my mom's in line. Well, I guess it's better than getting attacked by the cicadas that the East Coast is getting hit with right now. I don't know if you've seen any of that. My friend sent me a video of the tree outside his house, and it looks like the tree is moving. There are that many cicadas crawling on it. And that's a big no for me, dog. It's one of the reasons I left the East Coast. I hate bugs, playing video games. Yeah, it's 17 years already. Scary, right? So we got playing video games. We got oh my God, everyone has much better life than me. That's just sad. I just have a horrible life. No, just kidding. Studied, exactly. Well, that's going to be your life for the next several weeks. So the other group, just to let you know, the group that just graduated is now terrified and getting ready for their boards. So you can imagine what they're all like. They're all neurotic. And my phone, literally, as I'm sitting here waiting, trying this class, I'm watching my phone light up with text messages. That's been nonstop for like the past week and a half. So loads of fun. I am going to be teaching you both Kines, which is an everyday class, and then Therex, which is a Tuesday, Thursday class. So like tomorrow, get ready. You have me for all 4 hours. I will make a concerted effort to say, Therex is ending now. We are going into Kines, because I've been told before that because the classes blend so much, it gets people a little confused as to what's going on. So I will try to make a little bit better of a concerted effort for that. It does get a little confusing because I have taken my classes and made them so that if I'm talking about the knee in kinesiology, I'm talking about the knee in Therex. So they kind of work together. We will have lots of lab time. I am still working on some of the lab time with my lab assistants. So that is why your schedule is not fully up yet for me. It will be up, I promise you. I'm probably done with it today. I just had to wait for a couple of things from Dr. Reskin. So don't freak out that my full schedule is not up there. You're not getting away from me. Sorry, it's just the way it is. That'll get up today. Are there any, before I even start on kinesiology, are there any questions about this semester? Is there anything I can answer that you might have popped in your head while you have the clinical information, stuff like that?
Yeah, I had typed in the little box. I noticed there's not a schedule for your classes for homework. Is that going to be up soon?
That's going to be it. I was working with Dr. Reskin, who's my primary lab assistant, on some ways we're changing the labs. So that'll go up soon. Don't worry. Most of my homework is going to be just the check-in assignments like you had with Dr. Oh my God, why did I forget his name? Johnson. There we go. Wow, I just worked with him this morning with Dr. Johnson. And then you have a lot of quizzes in my class. So you'll have a bunch of quizzes to help you prep for the midterm and prep for the final. So I hope that's beneficial because, you know, if you're the one person that you're like, man, I don't have a lot of time and I need to prep, I would probably say prep and review the quizzes because they're going to help you. Wink, wink, nudge, nudge, Bob's your uncle. We will also do a day before your clinicals, one full lab before your clinicals, which will be a review everything day. So like if say you forget, oh, I forget how to do ultrasound. We will review ultrasound. We will review E-stim. We will review hot packs, cold packs, whatever anyone needs before they go on clinical. We'll do a review of that day. Lab partners, yes, did Dr. Sokel give you them yet? Okay, that's what I was waiting on. I thought she had written them up. I'll text her here in a little bit, and we'll get those out to you. No problem. Hopefully, well, actually, no, because by the time we get back to, well, I had to talk to her, see how she wants to do lab partners. By the time we get to on-campus lab, you will all be in it together. We're not going to be splitting up the labs because we pushed all of our lecture stuff up front so that we just do lab at the end of the semester. Nothing but like 4 days of lab for you guys. So let me talk to her about that. You
Do
will
we have a
lab
break?
partners. Uh-oh, I heard something.
Sorry, do we have break like between these couple months or no?
Do you have break between what?
Like throughout the semester, do we have a break or no? It's just
You mean
just wait till the end of the
or
semester.
like?
Yeah,
I mean, yeah.
No,
you're supposed to have breaks at the class. Did you not get breaks earlier?
no, I'm saying like a break, like a week break.
You know, but
No.
you have 2 days off this semester because you have Memorial Day and you have July 5th, which is the holiday for that. So
Okay. So
yes,
we have Memorial Day off.
3-day weekends.
Nice.
So take 2 3-day weekends. You do not get to take those from me. I want those, please. I need a 3-day weekend. I have a lot of things at my house in Tucson I have to get done. But yeah, no specific week breaks. All right, so it is now 4:14. Wow, that was fun. Let me get my PowerPoint brought up here. So the very first PowerPoint we are going to go through, as soon as oh, son of a biscuit. I brought up the wrong PowerPoint. That's math. There we go. There's the right PowerPoint. You guys don't want to learn math again, do you? I don't think so. Is there a break between clinicals? Well, I mean, yes, you have the week between the semesters. There's not really a specific break because what you'll have is you'll finish clinical 1, which is the 2-weeker. You'll have a week break. Now, somebody may have to work like 1 day or 2 days out of that week break to make up hours like she talked about, but I'll let her handle that because I have no freaking clue about that stuff. I don't want to deal with the clinicals. That's Dr. Reskin. Please let her have that. You have that week break, then you'll come back. So if you think this semester is compressed, next semester is really short. Next semester is 8 weeks, and I have to cram neuro rehab into 8 weeks. So next semester is going to go hard and go fast, just to let you know. And then you'll go right out in your clinicals. Then you'll have a week break between semester 4 and 5, and then 5, another 7-week course, then clinicals, and then a test prep course. So really, you're at the part where there's very little breaks, guys. Just warning you. You're at the starting to get real semester. How's that? All right, so let me bring this stuff up here. And I'm already recording, so that's a good thing. Angry cat always says no. That's right. Grumpy cat is my friend. And for those that don't know, if you didn't know that or not, her name was actually Tartar Sauce. It's such a weird name for a cat. All right, can everyone see the PowerPoint? I assume yes. All right. So here's the good news for this lecture, is that this is literally just a review of pretty much everything you should have gone through with Dr. Johnson. It's going to be fast. It's going to be furious. We're going to get through this, and then we're going to move right into real kinesiology. So this is pretty much a review. The first thing we're really going to hit new this semester is actually reviewing posture and doing a kind of posture overview. I know you covered it last semester, but how to look at a patient posture-wise, if that makes sense. So we're going to start off, the basics, right? Kinesiology, the study of human movement, which goes along with biomechanics, which is the study of the structure and function of biological systems, which goes along with kinetics, the study of movement, and kinematics, the study of angles and planes of motion. All of that comes into play in our body. You can get master's degrees in kinesiology. You can get master's degrees and doctorates in biomechanics. Those are all definite, pathways that you can eventually choose. I don't know why you would ever. I have one of the former instructors here from PIMA that taught anatomy for Dr. Johnson is getting his PhD in biomechanics, and I just can't imagine even doing that. Like, that is just insane to me, that his literally job is studying how every single joint in the body is affected by every single change you make in it. That's just not something I really am interested in. That's just way too much research for me. So remember, anatomical positioning, when you think of anatomical positioning, think back to the Da Vinci figure, right? The classic Da Vinci figure that's out there, that Da Vinci drew, where the face is facing forward, right? Palms are facing forward, and your toes are almost in a slight plantar flexed position. That's true anatomical position for both men and female, or men and women, right? We have our medial, right, towards the center. We have our lateral towards the outside. We have our anterior and our posterior. What's the other term for anterior and posterior you might see a lot?
Dorsal and ventral.
Dorsal and ventral, right? Or dorsal and volar is another term for it you may see, right? Distal to proximal, right? Proximal meaning closer to the body. Distal meaning what? Further away. Superior, head. Inferior, toes, right? We also sometimes will say cephalid, meaning towards the head, or caudal, meaning towards the what?
Tail.
Through the butt. Caudal is, your cauda equina is the end of your spinal cord, if you remember that from anatomy, right? Superficial, obviously, meaning shallow, right? Deep, meaning in the skin. Supine and prone, hopefully you guys have gotten that by now. I'm hoping. John, I'm worried about that with you, but I think you got it. Bilateral, contralateral, ipsilateral. This one I do want to hit really quick because this one sometimes confuses people, right? Bilateral meaning both sides, right? If I have pain in bilateral hands, that means both my hands are hurting. If I have pain in my right hand, but my contralateral hand has no pain, that means my left hand has no pain. Contralateral meaning opposite, right? If I have pain in my right hand and pain in my right foot, that would be ipsilateral pain, because that's on the same side. That is going to come into play next semester heavily when we talk about spinal cords. Because spinal cord injuries, there's a lot of problems that happen ipsilaterally on the same side of the spinal cord injury, and there's a lot of problems that happen contralaterally on the other side of the spinal cord injury. So it's really important to kind of understand that. Bilaterally, we just have to know is both sides, right? If you have somebody that's paraplegic, they're typically paralyzed bilaterally of the legs. Upper extremity, lower extremity. I hope I don't have to explain that to you. Trunk or core, we will use those terms interchangeably, right? Your trunk is this part of your body, right? Your thorax and your abdomen. That includes your core, which is your primary, your abdominal and lower back muscles. Neck, and then skull. I hit that a lot. Oh, these were the fun. I remember this lesson with Dr. Johnson when he was talking about these motions with you guys, and you guys just like brains exploding with linear and angular motions, right? Linear motion doesn't truly happen within body joints, right? Most of our motion is angular. It moves in more than one type plane, right? You could almost call shoulder flexion linear until you actually look at the joint and realize there's more than just a straight line occurring, right? When I think of linear, I think of like sliding down the hill, which is why I put that picture there, right? Or curvilinear is where you get that kind of that parabolic effect where you're jumping up in the air and you land somewhere else, right? Like a long jumper would be a curvilinear effect. Most of what we have in our body is angular motion. It's rotation around sockets and fixed positions, right? It's really interesting because initially when we started with PT, way back when we were rehabilitation aides, we focused on one motion at a time. So if you had a problem with the shoulder, we focused on flexion, flexion, extension, flexion, extension. But think about that. When you're like showering and you need to wash your head, it's not like you go flexion, flexion, internal rotation, abduction, put hand on head, right? You do a full kind of complement of the motion. So we have more angular motions than we do true just linear motion. In the martial arts world, you'll hear this quite frequently. Some martial arts are very linear and some martial arts are angular, right? A martial artist who's linear is pretty much moving back and forth in the fighting scene. I love watching linear martial artists in MMA because they usually get absolutely destroyed because they go straight forward, head forward, and meanwhile that person's dancing around them like crazy and that person has no idea how to defend themselves, right? Same thing happens if you watch a boxer fight an MMA fighter a lot of times, right? Boxers are very linear in the way they kind of operate, whereas MMA fighters traditionally, especially if you're a traditional martial artist, operate very angular. Combination of motions. Here we have a couple combinations of motions with the skateboarder, right? The upper body in this picture is moving back and forth. So that would be a linear motion, right? But that leg is kind of moving in an angular motion as it's going up and down to plant down, right? So within the joints themselves, we have a bunch of different motions, right? Flexion, extension, and hyperextension. When is something called hyperextension? Because this gets confusing, right? Because we talk about the shoulder, right? This is flexion of the shoulder. Extension is returning back here, but this going past the hip is also extension. It's not hyperextension because the shoulder is supposed to have some extension going backwards. Does that make sense? Now, elbow. Is the elbow supposed to have any hyperextension?
No.
No, right? That's bone on bone. But there it is, right? Riley said it. When it goes past the normal range of motion, we'll find somebody in here when we're doing goniometry that'll have 10 degrees of hyperextension of the elbow, where their forearm is kind of going downward. We had one in, I think, cohort 6, I want to say, that had 35 degrees of hyperextension at the elbow. Like the elbow went down and just went, and like all but pointing downward. That was just, every time I saw that, it just, I don't know, my stomach was like, okay, please stop doing that. Your elbow is not supposed to do that. Plantar flexion, dorsiflexion happens at the feet, obviously. One thing here. Yeah, exactly. Actually, the guy that had that was a break dancer, so that was part. One thing I want to stress here is some of the newer textbooks are calling plantar flexion extension of the foot and dorsiflexion flexion of the foot. That kind of makes sense when you think about it, because if you think about the way the foot is right here, when I push down, I'm going back towards the back, which is traditionally an extension motion. It's not going to be on your boards that way. So take a deep breath of relief there, right? It's going to be plantar flexion, dorsiflexion. But if any of you continue on, maybe to take an anatomy course or to go for DPT, some of the newer textbooks are getting away from plantar flexion, dorsiflexion and going with flexion and extension to make it uniform across the whole body. I love when they change stuff like that. It's so much fun. Abduction and adduction, right? Going away from the body, coming back in. Yeah, we're gonna hit that big time, Anthony. Don't you worry. Gait is one of the big parts of this class. Yummy, yummy gait. Oh, I could go into depth about supination and pronation, but I'm not going to right now. Let's just not go there yet. Horizontal AB and horizontal adduction occurs where? What joint? Shoulder, yeah, right? Horizontal adduction is typically what you think of when you bring in the weights like this, right? What's that called? Which machine is that? Those of you that go to the gym. What's that?
Deck fly.
Deck fly, good, right? Versus when you go out, that's called a typical reverse fly, right? Or a back post delt fly, sometimes they're called, right? So this would be your horizontal adduction. This would be your horizontal abduction, right? You're moving in a plane like this. Radial and ulnar deviation obviously occurs at the hand. Supination, pronation, you got that. Inversion, eversion, for some reason, I don't know why this is, but people have a problem with this. Did anyone have a problem getting this? No? I don't know what it is. Every time I bring this up when we get into class, people are like, oh, no, that's inversion, not eversion. Inversion, the foot goes in. Eversion, the foot goes out. That's the way I remembered it. Protraction and retraction is primarily the scapula, right? When you retract, you're pulling back like this. When you protract, you're coming forward. We sit typically in a protracted body, right? Because we got our phones. We're here. Or catching Pokemon as we go along, right? We should be a little bit more retracted, and we'll actually have some devices I want to show you guys then when we get to that, talk about how to get better posture out of that. Internal and external rotation. The shoulder is really easy, right? Internal rotation, your arm goes down. External rotation, your arm goes up, right? Or goes here in and out. Either way, right? The knee or the hip is kind of challenging because a lot of people get really confused about what is internal rotation and what is external rotation of the hip, right? I have a really easy way to remember that. If the knee is pointed in, it is what?
Internal.
Internal rotation. If the knee is pointed out, it's external rotation. That makes it pretty easy. Lateral and lateral or side bending, we have that at the spine, right? We also have it at the neck. And then circumduction is not a true motion because I love this. Somebody eventually will say, well, I know you're saying that we have 180 degrees of shoulder flexion, Mr. McKeever, but I can get 360. In reality, once you go past that 180, you're starting to combine abduction with external rotation, then going into internal rotation. Theoretically, that's a circumductive motion. We'll also talk about circumduction at the hip with gait, specifically abnormal gait when people are trying to avoid doing things like clearing the foot and stuff like that. If I lose anyone, please say something. All right, so add my little humor in here. Always remember to thank your skeletal system for the support it's given you throughout the years, right? It'll sink into some of you. I'll get a smile from John eventually. The axial skeleton, right, is our main trunk portion component of the skeleton. Appendicular is everything outside. Good news for you guys, as much as we beat that into you, there's not a likelihood your board's going to ask you the difference between an axial and appendicular skeleton. They expect you to know that, but it's not going to be, they're not going to say the forearm is part of the axial or appendicular skeleton. That's way too easy. But you guys know that at this point. what is the point of the skeleton? Well, the main part is to provide support and shape the body, right? And you just have to look outside that everyone's shape is different, right? Some people are built big, some people are built small, some people are built wide, some people are built really skinny. And it may not have anything to do with their body weight either, right? I mean, I look like I'm wide, but I have no fat on my ribs. Those are ribs. My rib cage is huge, right? It's to contain my huge heart that I have for caring for you guys. But it provides support, it provides safety, right? Protects our vital organs. Just imagine if we didn't have a cage around our heart and our lungs, how easy it would be to basically kill ourselves, right? We'd fall down face first and puncture a lung. We still do that sometimes. It assists us in movement, but one of the most important jobs about the skeleton, one of the things we forget about, is the manufacturing of blood, right? Where does the manufacturing of blood occur in the skeleton?
Your red bone marrow?
Yeah, in the bone marrow, right? Primarily bone marrow, the soft, spongy bone, right? And, you know, when you have people that have something like a bone cancer or something like that, that's going to systemically affect the whole body then. Because then blood production is going to go down. And maybe then the spleen has to produce more blood than it can, and then the spleen ends up with problems. So the bones produce a lot of our blood cells. But the other thing is, it won't produce blood cells unless the patient is moving, right? So if a patient is very sedentary and doesn't move a lot, what we find a lot of times is blood production goes down. Because by moving the bones, it helps promote those cell regeneration and regrowth of blood cells. So this is just, you know, your fun facts here. Exoskeleton, we remember, is 80 bones. It's the central and midline. It contains the skull, the hyoid bone. Where's the hyoid bone? Yeah, right? That's one of those that's one of the bones we focus on in the martial arts because that's a good strike point. The rib cage, our sternum, and our vertebral column. That's the primary part of our exoskeleton. Appendicular is everything else. 126, upper and lower extremities, right? The pectoral girdle, shoulder girdle, arms and forearms, hands, pelvis, thighs and legs, feet and ankles. Although some people don't have ankles, they just have cankles. It's just one thing going the whole way down, right? This is what we were just talking about with the production of bone, right? We have the hard bone or the compact bone, and then we have the cancellous or the soft bone. Both of those have specific purposes, right? The compact or the cortical bone is the support of the body, protects the organs, stores our calcium, right? Remember back from anatomy, what specific gland is kind of responsible for maintaining calcium balance? Do you remember? The calcitonins, yep, we got the hormone. What gland produces that?
Your parathyroid.
The thyroids, yeah. The parathyroid works in combination with the thyroid to produce calcitonin. Yeah, so good, right? So if you have something where you have problems with the thyroids, guess what happens to your bones? They often get weak, right? Or they can get over-calcified, right? And then some of that spongy bone then becomes cortical, which would be equally as bad. It's very dense and strong, or it should be as long as you're moving. It is 80% of the weight of the skeleton, and it forms our outer shell. The cancellous bones, that's spongy stuff on the inside, right? And if you've ever cooked a ham before, or actually ever butchered an animal, which I don't think any of you really ever have probably, but I have coming from where I'm from, right? If you cook a ham, when you get that ham bone in the middle, you can see that soft, spongy bone in the middle of the ham bone. Acromegaly, there's one of them. Yeah, exactly, Joe. I know, I'm sorry, I'm definitely not vegan, so I apologize to any of you vegans in here. I grew up butchering animals. That's just the way it is. We did it as humanely as possible, not with a pneumatic hammer, that's for sure. That's not very humane. They're located both in the shaft of the bone, right, and also at the ends. They're very vascular, whereas the compact bone is not vascular at all, and it is the inner portion of bones. So this is kind of looking at the different parts of the bone, right? here we're looking at a vertebrae, right? And the inside is kind of our soft bone, whereas that outside is that compact hard bone. This is a normal bone, right? Now let's take a look. This is somebody that's got osteoporosis, right? Who's going to develop osteoporosis eventually?
Everybody?
Everybody. Everybody's going to develop it at some point, right? Well, maybe, I mean, maybe we won't make it to osteoporosis age, but who knows, right? Osteoporosis is a equal opportunity infector. It does affect women more than men because of hormonal changes, right? Sedentary people, especially old people. Yep. So if you look at this osteoporotic bone, just imagine how easy that is to fracture that bone, right? And this is really interesting. You'll find this when you get on the field. You'll have patients that come in with a spinal cord fracture, and you'll ask them, what did you do? And they'll be like, I sat down. And just from sitting down, because their bone is so soft, it just snaps. And it's really sad. That tells you they've been kind of sedentary, or they don't have a very healthy diet, which is also equally problematic. So when we're talking at the actual structure of the bone, right, we have the epiphysis, I can say it today, my brain is working. The ends of the bone, we have the metaphysis, which is the center, kind of the transitional part of the bone. And then we have the diaphysis, which is the shaft, right? The metaphysis typically contains the epiphyseal plate. The epiphyseal plate is important for who?
Children.
Kids.
Children, yeah, right? And I don't know if you guys can remember back to the days when you were a kid, because some of you are still like Brooke's like 12 years old, just as she is. But if you remember back to growing up, do you remember getting those growth pains growing up where your body just ached and you felt like you're 90 years old as a kid? Did any of you get that? I know I did. Like, especially I hit it when I hit my growth spurt. My bones just ached. And it was annoying. And I had Osgood-Schlatter's, which we'll talk about, which is a big tibial tuberosity when I was a kid, because my epiphyseal plates were closing. That's important to know for patients when we're doing stuff like ultrasound, right? In your knees, exactly, yeah. And then once we get older, we just get pain from weight bearing on our knees. It just sucks. We can't get away from it. When we're looking at this, the main thing to think about is a lot of your blood vessels are going to be out here at the ends. In here, there's not a lot of blood vessels, right? It's the same thing with your cartilage, right? There's not a lot of blood vessels in the cartilage itself. So that's why when we get something like, when we get a fracture up through this soft bone, it may not heal as well as a shaft fracture. Because a shaft fracture, we can pin and rod it and it stays together. Up here, because of this soft tissue, we may have to actually replace it. Right? We may have to do something like a shoulder replacement or a hip replacement, stuff like that.
Even though the calcaneus bone is vascular, it still doesn't heal very well.
Well, the problem is a lot of times when you get an insult to it, there's an insult to the vascular problem too, or to the vascular structure. So that vascular structure doesn't grow back as fast as the blood structures do, or as the bone structures do. So it's now not getting as many nutrients and doesn't grow as effectively, if that makes sense. So like you'll hear this a lot of patients that have a hip fracture, and doctors like it when hip fractures come in and it's through the main shaft of the femur, which is pretty rare because the shaft of the femur is pretty strong, because they can rod and pin that, and that patient goes out, they're in a little bit of pain for a couple weeks, but for the most part, they go home pretty good. If you have it up at the head or get a necrotic head of the femur, a lot of times the only thing we can do at that point is lop it off and put a piece of metal and rod and pin in it in there and go with the hip replacement. And then again, we've gotten better at our hip replacements, and I will post videos for you guys to watch of hip replacements. We've gotten a lot better, but hip replacements need revised about every 10 to 15 years. So think about it. If you're like 35 and need hip replacement, think of all those revisions you're going to go through your life cycle, right? It's kind of scary when you think about it. You know, we like to put off replacements as long as we can, so maybe they don't have to have as many revisions. Oh, the types of bone, right? We have our long bones, which are, guess what? Long. We have our short bones, which are not long, but usually wide. We have our flat bones, which guess what? They're flat. I always love this, like this, there's no point to this. We have our irregular bones, which are usually our manual muscle attachments, right? And then our sesamoid bone. Where's our sesamoid bone at, primarily?
Our foot.
Okay.
Kneecap.
Kneecap's the big one I think of, yeah. I mean, there are some other places sesamoid bones form, but the main sesamoid bone is your kneecap, right? We will actually talk about a little sesamoid bone you can develop in your gastroc called the fibella, or little bean. And if you actually have a cat and you can feel their gastroc, you can actually find this little bone that sits between the head of the two heads of the gastrocs. And it creates an extra tendon. What do you think that bone helps them do?
Jump.
Yeah, jump. Right? They jump so much, they developed an extra bone there to create an extra pulley system to help them jump high, especially like Bengals or your, oh my gosh, there's another one that I can't think of right now, servals, stuff like that. You can really get in there and feel that bone in there that helps them jump high. My friend has a Bengal, and every time I come in to see him, it's up on the top of the refrigerator, just sitting up there chilling. And it just goes from the floor straight up on top of the fridge. It's to increase the moment arm, exactly. Yep. Time is 42. So what is our purpose of our joints? Well, to allow motion, support weight, and provide stability. The main thing you're going to need to understand about the joints, because we're going to go into them when we talk about goniometry, is the types. Right? We've got fibrous, we've got cartilaginous, and we've got synovial. The synovial is kind of our most common and does allow us the most movement. We're going to look at some pictures of them going forward here. So our fibrous joints we have are the synarthrosis, syndesmosis, and gomphosis joints. I love the gomphosis. I just think that's one of the fun words of the human anatomy, gomphosis. The synarthrosis are our fusion joints, right? They're the joints that are kind of fused together. That's the sutures of your skull that when you had a baby, when you were a baby, those were open, right? It allowed your skull to grow. And then once your head got so big, it stopped getting any bigger. Where are your two main syndesmosis joints at? I got a picture of one of them.
Let's see your pubic symphysis.
Okay, symphysis we'll talk about in a sec. There is a syndesmosis joint there. You're exactly right. Good. I didn't think about that one. That's one.
Is it your vertebrae?
What's that?
Your vertebrae?
There is a little bit of one in. Okay. Yep. I didn't think about that one either. Good call. I was mainly thinking the two that cause us the most problems in physical therapy and the ribs. Okay, fine. The tib fib and the radial ulnar. Right? Because between the radius and ulna, there's a long syndesmosis growing, right? And then between the tib and the fib, there's another one. The tib fib gives us a real problem that runners experience a lot. Does anyone know what that is?
Shin splints.
Shin splints, yeah. Irritation of that syndesmosis joint, right? And you guys learned a treatment for that last semester, didn't you? What can you do for that? What modality?
Manual.
You can do manual, okay.
Ice.
Ice, yeah, ice massage really works well for shin splints. It sucks because it gets cold really quick if any of you had that ice massage done, right? And some people just don't like ice, but it does help that. And then our gomphosis are our teeth joints primarily. That's mainly where you'll see those, the peg and the socket joints. The neat thing about our gomphosis joints is they were designed to be replaced. When you think about it, right? We're born with baby teeth, and the baby teeth do what? Fall out so the tooth fairy can give us money, right? Didn't the tooth fairy come to visit you guys? And then in my area, when those teeth fall out, they, in any other area, you can put that Ambisol on it when the teeth are growing in or when the teeth fall out. In my area, they just do Jack Daniels, and that suffices as Ambisol. And I wonder why I have problems. No, just kidding. Cartilaginous, the main cartilaginous joints obviously are intervertebral discs. Our sternoclavicular joint and sternocostal joint, or sternoclavicular, sternocostal, right, are all those that are out there. Pubic symphysis is a combination of a cartilaginous and a little bit of a syndesmosis joint. There's some motion there, but not a lot. I've got a great picture from my ex-wife when she rolled over in an ATV, where that joint is literally laying over each other because it completely separated. I don't say it's great because it was fun, but to me, it's scientifically interesting to look at, right? But that can tear apart. Any of these joints can tear apart. There's a lot of times we'll talk with patients that have pain right here, right, at the sternocostal joint, the sternoclavicular joint, that we'll mobilize that and we'll find out we move that clavicle and that clavicle just goes up and down like candy. We're like, man, that's just so loose. It should be nice and tight and doesn't move. That's a reason why they're getting pain, because it's not supposed to move. And then we get our synovial. The synovial joint, the main thing is there's no direct union between the joints. And the main thing with the synovial joints is they're named by how many different directions they go, right? A uniaxial, a biaxial, and then a multiaxial. Our uniaxial joints are usually our hinge joints and our pivot joints. They usually go into like one motion, like flexion extension. Our biaxial joints are our condyloids or saddle joints. They allow a little bit more motion, right? Because they allow two axes of motion. And then multi-axial, like our ball and sockets, so our shoulders and our hips, allow a lot more freedom of movement. What though happens, the further we go down, the more axials we get, the less stable the joint is. Does that make sense? So when you think about it, right, your knee joint's pretty stable because it only has flexion extension. But then let's go down to the ankle once. Does the ankle have a lot of motion down in it? Right? It's got dorsiflexion, plantar flexion, inversion, eversion. There's actually pronation and supination in the ankle too. So you get all that motion and that leads to all kinds of problems, right? Ankle sprains are really common. I'm sure if we asked in this class, at least 30% of you have had an ankle sprain at any time, any given time, right? Playing basketball commonly, stepping off a curb is how I always do mine, because I forget that you're supposed to step down and just kind of fall on my face. So when we talk about the joints, we're going to look at the joints from the full structure of them. We have the bones that make them up. We have the ligaments and tendons that hold them together, and then we have the capsule that keeps everything intact, right? The tendon connects muscle to bone, ligament attaches bone to bone, right? So when we're in a knee, the patellar tendon is attaching the quad to the tibia. The ACL is attaching the femur to the tibia, right? So bone to bone versus muscle to bone. In there, we have synovial fluid, which is basically, I like to think of as the WD-40 of our joints, right? I know this says the egg yolk. That's what the book calls it. I don't like that term really. I just like to think of it as the WD-40 of the joint. When your synovial fluid is kind of dried out, your joints don't move very smoothly. Think of somebody that's got like rheumatoid arthritis. If you've ever seen their hands where they get all gnarled up, it's because their synovial joints have dried up. Then we have our bursas. The bursas are kind of like, I like to think of those, it says the egg white. I like to think of those as like our padding. We have bursas all over our body and most of our joints. The job of a bursa is to provide some cushioning. And then we have two primary types of cartilage, right? We have our articular cartilage and our fibrocartilage. Articular is exactly like it sounds. It helps articulate, allows for motion. Versus fibrocartilage is our shock absorbers. So in the knee, if we're looking at the knee itself, right? On the bottom of the femur, there's articular cartilage. On the top of the tibia, there's articular cartilage. But then you have your meniscus between them. And those meniscus or menisci are fibrocartilage because their job is to absorb the shock of us running or walking. And it's pretty common for folks to get tears of those. And what can we do for a tear of a meniscus? Is there any way we can repair it?
Ultrasound?
Well, we can do ultrasound. Okay, yeah. We can cause it, reduce it, and we try to heal it that way, right? But as far as most of it, if it tears, surgery and cut it out is about the only thing we can do. And you'll find it's interesting. Most of the patients that get meniscectomies, at least in my experience, come out worse than they did when they went in. It's weird how that happens, that patients that go in for surgery don't come out better. But we also have to look at all kinds of other problems that go along with that as well. We'll go about 5 more minutes and I'll cut you guys loose. So here's looking at that joint capsule. Why do we need to know about the joint capsule? Well, joint capsules are what we're going to talk about when we do mobilization of joints. And we're going to talk about joint mobilizations in this class. But if Dr. Reskin ever asks you, can a PTA do joint mobilizations? What should your answer be? No, right. We do joint mobilizations, just to let you guys know, right? Well, yeah, we'll talk about the grades. You definitely know grade 5s. I mean, I've been trained on grade 5s and I won't do grade 5s. But let me show you something here. I just did a grade 5. Right? Just pop my knuckles. That's a grade 5 joint mob. Right? And in the pediatric world, especially with a kid that's got hip dysplasia where the hip's constantly popping out, every time I pop that hip back into socket for the kid, guess what I'm doing? A grade 5 mobilization. If I have to go get my PT every time I have to put that hip back into place, I'm going to get nothing done. I'll be like, Sarah, I need hip pop back in. Sarah, I need hip pop back in. Never going to get anywhere. So you'll find that joint mobilizations are a very gray area. And we'll talk specifically about that, and I'll give you ways to kind of cover yourself a little bit on that. The labrum. Okay. I told you my story about my patient with this, right? I think that'll be a great story to end on. Did I tell you about my patient with this, the shoulder labrum tear? Oh, this is great. It's about a year ago. I went to see a patient in home health, 70-year-old Marine. And he's in the living room. I go to see him. How you feeling today, Bob? His name wasn't Bob. I'm just going to use Bob as an example. He's like, oh, I'm doing okay. Ever since the doctor fixed the labia in my shoulder, I'm feeling a lot better. And I hear his wife in the kitchen, and she is absolutely dying. And she's like, come here, come here, come here, come here. Like, yeah, she goes, don't tell him it's not called a labia. She goes, every time he says it, it just makes me laugh. So if he wants to call it a labia, it's called a labia. So the poor guy thought he had a labia in his shoulder. He was trying to say it was labrum, right? Labia is a different body part. If I have to explain where that is, then you failed anatomy. So the labrum the job is to deepen the fossa, right? We have a labrum in the shoulder and we have a labrum in the hip. The downside to those is they're subject to tears. I have a torn right labrum from playing football, right? I'm guessing probably from too much 3-point stance in football where you get down and your hands on the ground and, you know, being big didn't help. And the doc's like, well, I can go in and cut that labrum out, or you can just live with it. At least my doc was honest. But the labrum's job is to provide a little bit more of a socket for that head of the femur and the head of the humerus to sit in there and makes the shoulders a little bit more stable, even though they're those multi-axial joints. The other job of it is to keep a suction on that, right? It keeps the head suctioned into the fossa. Because if I come in here and I get a labrum tear of the bottom part of my shoulder here, what's likely to happen to this humeral head is it'll slip out. And what's that called when the head of the joint or the head of a bone slips out of those ball and socket joints?
Dislocation.
Yeah, dislocation. Yeah, right. If it just slips out a little, it's a sublux, right? Or subluxation, where it just slips out a little, where it's not actually out fully, but it's not in the right place. Dislocations where it's like, nope, it pops out. Now, as PTAs, we can just put it right back in, right? That's a good thing to do. Shoulder pops out of joint, just pop it right back in the joint. My instructor in the martial arts did that to me when somebody dislocated my right shoulder. And then when I went through PTA school, my PTA instructor was like, are you kidding me? Do you know how many nerves and blood vessels are in the axilla of your arm, and he just popped it right back in without any medical knowledge? Oh, I didn't think about that. Right? Sometimes it's not the best idea to think, oh, well, just, I always think of, what was the movie with Mel Gibson? Lethal Weapon, where he pops his shoulders out of joint to get out of the straitjacket. Not very healthy for your shoulders. I'm just saying. The doctor, but he said we were successful. Yeah. Right. That's it. And that's usually how it starts right there, Jason. My drunk friend once did. Right? Anytime a story starts like that, it usually is not always the best ending. All right, I'm going to stop sharing here because that's about it for the day, because I think you guys are about fried.